Welcome to the 11 o'clock breakout session, Empowering Clinicians in Payment and System Delivery Reform. That's not where you're supposed to be. This plane is landing in Chicago if you're on one plane. So you can read the full bio of Neel in the program, so I'm going to introduce him in a slightly different way. I'm Judy Lauren. I work in the data systems portion of Coalition. And I want all of you to think of a case where you're working within a system. And it could be that you have a student in the school system, could be you're a teacher, could be you're a bank teller, could be you're an employee of an organization. But you're working within a system and you have a goal to accomplish. And you know that your goal would be easier if the system were different. So what do? You have to serve the immediate need, and you also want to improve the situation. So I'm going to say what you would do if you're an individual physician trying to serve patients who can't get information about the cost of their health care. Okay? Well, if you're a person of vision, energy, and resolve, and you're working as an intern at Brigham and Women's, you use the other 100% of your time to start a new organization. So I'm really happy to introduce to you today the man who is literally writing the book on understanding value-based healthcare, Neel Shah.
Thank you. That was a really great introduction. Judy very kindly sat next to me during the last session, and it's like, you know, you have this bio, but it'd be nice to introduce you more personally. And nobody ever asked me that question before, so I was like, we could talk about my puppy. And this was a much better introduction. So, you know, I think probably the first thing that I want to say is that when I was a graduate student, I had a very esteemed professor who used to say that healthcare costs were an intractable problem. And I didn't totally, I think, appreciate or understand what that meant, but part of why I'm excited to be here is because all of you are very clearly demonstrating that it's not an intractable problem. You have good, strong leadership, you can make forward progress. The piece in particular, though, that I want to talk about today is that 90% of healthcare spending easily is determined at the point of care. Can you all hear me, by the way? No? Yes? Sort of? It's a nice small room. I'll try my best to project. So about 90% of healthcare spending is determined at the point of care between a clinician and a patient. So it's probably where 90% of the opportunity to decrease healthcare costs is, I think. And yet, when we think about value-based care, when we think about value-based insurance designs, most of that is targeted at the other 10%. As we heard from the panel today, it's really thinking about where patients ought to go to get the most appropriate care. It's much less about what to do once the patient is already through the door, where a lot of the low-value, high-cost care happens. Just really quick, since we have a relatively small room and we can just have a conversation, who's in the room? How many people here are clinicians? How many people here are representing purchasers? Anybody? Health plans? Work in provider organizations for non-clinicians? If I left anybody out? Patients.
I'm a patient.
Well, we're all patients, to be honest, which is part of what is so interesting about this. So I'm going to take a quick poll maybe to get us started. As patients, since we're all patients, how many of us think that our clinicians, our doctors and our nurses, ought to take some responsibility for the cost of our healthcare system? Raise your hand if you believe that. So there seems to be broad consensus here, but it's not true everywhere I go, and it certainly wasn't true when I first started talking about this 5 years ago. It's actually pretty controversial to put costs in the lap of frontline clinicians. So keep your hands raised if you believe that this is true, that frontline clinicians. So now continue to keep your hand in the air if you also believe that healthcare in the United States, as it stands now, is a good value. People like me, as many people that raised their hands earlier, that's a little bit awkward. And the question is, one, what's going wrong, but then, of course, more importantly, what can we do about it? And really, whether we like it or not as clinicians, I think increasingly we're being asked to consider costs while we care for patients in tandem, either because an administrator or a patient asks us to. But I think the challenge for a lot of us is that we don't feel like we have the training or the skills or the system support to do this in ways that we feel are ethically coherent and also reasonably pragmatic with all the other things that we're sort of shouldering. So that's really what I want to talk about. Maybe what I'll do is I'll leave the slides aside for 5 minutes and tell you a little bit about how I became involved in this work, because I think it says a lot about why this era of healthcare reform is so different from prior eras, why 2014 is so different from, say, 1994. And, you know, because most of what that health economics professor was telling me about costs being this intractable problem was based on 1994 and all the lessons that was supposedly going to portend. So I was telling Judy earlier that I signed up for medical school when I was 18. There's this program at Brown that I lovingly call the Brown for Life program, where you commit to 8 years in Providence, Rhode Island. Moved there from New Jersey, and I basically I had this idea of what being a doctor would be like when I was 18, which I didn't really question until not even like I kind of rolled from college right into medical school, and then you spend the first 2 years in a classroom. And then your 3rd year, they finally let you put on a white coat and carry around a stethoscope and touch real patients. And of course, at that point, you're in like 25th grade. And you spent like a quarter century preparing for this moment. And the veil suddenly gets lifted and you see how healthcare is actually delivered. And in some ways it was really exciting. I tell our 3rd year medical students this all the time. Part of your job as a 3rd year medical student, which you never get to do again for the rest of your career, is to walk into every single room in the hospital and try to understand what happens there. And you never really get to do that again. So that part's really interesting. But of course, it was disillusioning at the same time for all the reasons that all of us are here today. And in particular, one of the things that I noticed is that clinicians often make decisions in a vacuum, particularly with regard to cost. We have no idea how our decisions impact what anybody pays for care. Not the institutions we work for, not society as a whole, and not even for the patients that are directly in front of us. So after my 3rd year of medical school, that's when I started to question this whole career pathway, and I left for a few years. I worked in politics, and then I found myself at the Kennedy School of Government, where suddenly I was around people that were not just interested in healthcare, but education, and building roads, and protecting our borders. And I realized for all of them, healthcare costs were sort of the holy grail. That was the thing that was crowding out spending on everything else. And in particular, I had this sort of medical student idea where I was going to unveil costs to doctors in an emergency room and see how that influenced their behavior, and then write a paper about it, because that's what you do as a student. And because of the people that I was around, it ended up becoming a nonprofit. I was this is sort of like the insider story to this, but I was taking a class taught by a guy named Chris Stone, who was teaching people about nonprofit management at the time, and now is running the Soros Foundation. He's a pretty serious guy. And there's this Harvard business plan competition that happens every year. It's like a thing. And he helped me write a business plan that would go along with this idea of trying to bring costs to physicians. And we did pretty well. I had a lot of really good help. I was able to, I was a medical student, so I didn't even know what a P&L sheet was. I didn't know how to read a ledger, but I had other people that could help. And we entered into the competition, and we got pretty far, but when we got to the last stage, they had these sort of luminary judges from Fortune 500 companies, and they decided that our basic premise was flawed. They just didn't believe that physicians actually knew that little about healthcare costs. And so they were like, your business plan is solid, but the premise, there's something that you don't know. So we took the small amount of money that we got from entering the competition, and we made a website, and we incorporated. This was a month before my intern year, which is a terrible time to start anything. But we had a very uncreatively titled and exceptionally well-timed name. So we called it Costs of Care. And this was right after the president got elected and healthcare reform was at the top of the agenda. And so depending on the news cycle, as a phrase, cost of care was Googled between 3,000 to 5,000 times a day. And so, like, I mean, you can't make this up. And when money can't buy this kind of like search engine optimization, you're at the top of the Google ranking. All of a sudden, when people type that in, we still are. And at the time, it was just a website with a. This is when I met Judy's son, actually, Sam, who's a Harvard College student who like reached out to me and was like, "Do you need help?" While I was getting crushed as an intern. But he was one of like actually, hundreds of people who found this website that just had a manifesto about what the role of physicians ought to be, and wrote to us. And as an intern, we were a nonprofit in name only, and I had an 80-hour-a-week day job. So we tried to think about what we could do on the margins, like on the nights and weekends that I wasn't working. And we did this, very small project that Sam helped with that I thought would just be fun, where we called it an essay contest, and we invited frontline clinicians, doctors, nurses, and actually patients as well, all over the country to send us not policy solutions, but stories that illustrated bedside level opportunities to improve the value of care. We got all the major payers to put up some money for it. We got all these, some high-profile judges. Got Mike Dukakis, and we balanced him out with George Bush's HHS secretary. We got Atul Gawande, the dean of Harvard Medical School. All these sort of big people. But even then, I thought, if we got 3 stories, because we had 3 prizes, I could save face at this point. And we actually got 300. And they came in from all over the country. And what was particularly remarkable about them, one thing I learned right away is that a good story is worth 1,000 academic papers in terms of motivating change, which is at the end of the day what we're trying to do, to the point of our keynote. The other thing that I realized is that, when you get the same story in North Dakota and Florida and California and New York, there's probably something to that. So we're actually actively learning about what was going on in a relatively unique way. People call that crowdsourcing now. We also found that when we got clinicians to write their names on a story and admit basically that something worked out not well for a patient, that was really unique, and the media really were into this. So basically we got these stories in almost every major media outlet, largely because it's so hard to get clinicians to admit when things don't work out well. And yet this was something that was really touching a nerve, not just for patients, but for clinicians. So we're saying we're making decisions in a vacuum, starting to affect our patients, and we want to be part of the solution. And so that's suddenly we had a national profile and became a real nonprofit. So that's sort of the short story. And in many ways, I don't think that would have been possible in 1994. And I'll say a little bit more about that. I think what I really want to do over the course of the next, 45 minutes or so, is give you a sense of, where clinicians are with this, how clinicians think, if that's possible to do. I think that's probably the most important thing, because in many cases when we're doing low-value things, we know we're doing it. So why are we doing it anyway? And then maybe if we have time, I don't have a monopoly on ideas about this, but offer a couple of the ideas that we've gotten from all of these clinicians all over the country who are in the trenches and trying to think this through. I guess a few people watched this show. It's a TV show, Scrubs. It's based on the book House of God. It's actually based on the hospital where I'm now working. It's a different place at the time. I used to love this TV show. Quirky characters. It's really funny. But then, and it's mainly about the interactions between this intern, JD, and his grown-up doctor, attending. And to understand the way that doctors think, I think the first thing you have to understand is the way that doctors grow up. And I remember when this show stopped being funny to me. It was a very sad day. And that was, of course, when I became an intern, because I was JD. And everything that was funny about the TV show was like these really deviant behaviors that we put physicians through in the course of their training. What's particularly interesting about this I think, is how we take all these like people who start off normal, like when we're pretty normal when we started, and then we very quickly like normalize deviancy. And so, in the nonprofit, one of the first things that we did is we made a video called "What If Hotels Built Like Hospitals," and it very quickly went viral. And essentially, I'm not going to show the video in the interest of time. You can find it on YouTube. But basically, there's a hotel runs up a $20,000 bill, and then the guest calls the concierge, or calls the front desk, who explains that the concierge ordered like a prophylactic taxi just in case. This is an idea that a lot of educators call a hidden curriculum. So I think what you need to understand is that it's not just that clinicians aren't taught anything about healthcare costs. It's that the way that we're taught actively trains us to be terrible stewards of resources. And this plays out in a lot of different ways, but one of the biggest is that every single New England Journal of Medicine case report, every conference that we have in the hospital is about things that are exceedingly rare. And so we spend a lot of our time chasing down things that are very uncommon. And when you're chasing down things that are uncommon, you test for lots of stuff. Part of my job about a year ago was I was a chief resident on our service at the Brigham, and I had to run a morbidity and mortality conference every week. You guys know what that is?
Yes.
You've seen one on Grey's Anatomy. That's not actually that far off from what life. So you're basically like staring at, you're standing in front of a room that's sort of like this, only feels much more like a firing squad, and you're answering for all the things that didn't go so well that week. And when you're doing that, you're, basically being chastised for all the things that you didn't do but could have done, and you're almost never being criticized for the things that you did do but didn't have to do. And of course that influences the way you think. The other piece of all of this is that there's a sort of fundamental misperception within the profession, I think, not even as much now among the public, but really within the profession, that considering costs isn't aligned with patient interests. When I started to do all of this, the motto of my hospital was everything possible, period. And the motto of the hospital across the street was until every child is well, period. And there's something about, I think, the ethos of those mottos that's worth preserving, but without deeper thought or more nuanced thought, it seems like it's directly at odds with this idea of trying to drive better value out of healthcare. So part of, I think, what makes 2014 different than 1994 is that, today a clinician in the trenches is feeling pressure to consider costs that's coming from two different directions. It's coming top down from policymakers who want more accountability in how we're spending our money. But what's really different is that it's coming bottom up from patients who want more transparency in how we're spending their money. And in 2014, this is a little bit more possible than in 1994. Part of the issue is that there are a lot more patients on high deductible plans than ever before. Part of it is that we make purchasing decisions based on transparent cost and quality information for every other commodity, like Yelp, Travelocity, Amazon. And so there's an increasing expectation that we ought to be able to do the same thing for healthcare. And that's really different today, even compared to last year. Do you guys know who this is? We're in Maine. When I'm in other parts of the country, people guess Angela Merkel, who's the Chancellor of Germany. It's not Angela Merkel. It's Martha Coakley, who's running for governor, is our Democratic nominee right now. Interestingly, our whole gubernatorial race is going to be about healthcare reform. We're 7 years ahead of the rest of the country in terms of covering all of our citizens. We're super proud of that in Massachusetts. Now we're 7 years ahead in terms of running out of money to pay for it, and we're considerably and so, like, the race is, well, first of all, just the Democratic primary. It was Don Berwick, the guy who coined the triple aim, was running against Martha Coakley. Now it's Martha Coakley against Charlie Baker, who ran Harvard Pilgrim Health Plan. And this is going to be all about healthcare reform. When I was training at the Brigham, though, Martha Coakley was, people now say that she hasn't gone far enough, but the 800-pound gorilla in Massachusetts, it's not the public payer, it's one big provider organization that's basically setting prices. And at the time, Martha Coakley was the Attorney General, and under her scrutiny, my hospital system was being threatened, well, essentially being accused of collusion. And we were being told that Mass General and the Brigham were going to be broken up. And so, as part of the deal to avoid that, our hospital volunteered to
that was a nice euphemism.
cut hundreds of millions of dollars out of our operating budget within 2 years. They just agreed to it. Interestingly, now that I've been around the country, I thought we were relatively unique because we're in Massachusetts and partners and we're really expensive. Actually, most big provider organizations around the country are actively seeking ways of cutting hundreds of millions of dollars out of the system. We heard this morning about how hard that is. It's easier to manage the revenue side, harder to manage the cost side. And in particular, the reason this matters so much today is that revenue is getting harder and harder to predict under these value-based payment models, and people are seeing their top lines stay relatively flat. So how do you protect your margin? You have to drop out the cost, and you can lay people off. You can do some lean supply chain management, but that only gets you so far. You have to be able to bring your clinicians along at the end of the day and think about utilization. And so this was sort of the burning platform environment that I was in when we were starting to think about this. So, as you guys know, we're on the precipice of a major radical shift in the way we pay for care in this country. I don't need to go into that. At the same time, healthcare costs are rising. They raise about 10% per year in terms of the share that households are contributing. Here's our Massachusetts experience. So, 98% of our citizens are covered. Interestingly, since we did that, rates of medical debt have not gone down in Massachusetts. They're not rising at the same astronomical rate that they were rising in the rest of the country, but they stayed pretty flat. And in fact, they're more insured and non-elderly adults who say it's harder to pay their medical bills than ever before. How is that possible?
Well, the structure of the insurance market, co-insurance and
Yeah, totally. So even today, and this is like the way we did this is the model for how we're doing this across the country now, right? So you can go to pretty much any health exchange and just try to sign up for a plan. Has anybody done this? So, they rank them like platinum, gold, silver, skull and crossbones. This is like a common behavioral economics trope. Like people don't sign up for platinum usually because that feels like a luxury expense. Like when you hear things like this, generally people go for the top. They start at the top thing and they go 1 or 2 rungs down. You don't want the one at the bottom either. So you can sign up for like a silver plan, almost any exchange in the country, and be looking at a $5,000 deductible. So you're insured, but no matter who you are, like you're, 1 emergency room visit, easily 1 prenatal ultrasound that you don't need. I'm an obstetrician, I should have mentioned that. Deliver babies for a living. And I see this all the time because, my patients are young, healthy women who are very discerning about their health choices because they're pregnant. So online anyway, looking at it, this is what people tell me. I'm not stereotyping. I guess I am stereotyping, but people who stereotype for a living tell me that this is reliable information. So, when you think about all these new price transparency tools, apparently my patients are the demographic people are trying to target. It's not the old over 65ers. Anyway, so there are a bunch of states that have legislation on the books or that are already passed or working on price transparency efforts. I think actually Maine and Massachusetts may have been the only 2 states in the country that got A's. There's an organization called Catalyst for Payment Reform that gives states report cards. So Maine's kind of on the leading edge of this. Our tool in Massachusetts exists, but it's not very good. But just to give you a sense of what we're dealing with in Massachusetts, these are 3 hospitals within a 3-mile radius of each other. And this is what private plans are paying for first trimester ultrasounds. So they're pretty different. And there, to my count, is something like $10 billion right now in the Silicon Valley to create essentially a Yelp for healthcare. Castlight Health is the one that gets the most attention. I used to call this a cottage industry. It's not a cottage industry anymore. We're talking about billions of dollars. I used to talk about how it was a big deal that Castlight, raised hundreds of millions of dollars in venture capital to create the Yelp for healthcare. Now the big deal is that they IPO'd, they had their public offering, and they were valued at $3 billion. By the way, all these tools, it's okay, I don't think I'll offend anybody if I say this on camera. I mean, they're not very good, despite the large amounts of money. And part of it is that people don't shop for echocardiograms. Like they have chest pain. And I think there are a couple of ways that healthcare is justifiably exceptional from other industries. A lot of what these tools are, and by the way, it's not just sort of third-party private sector companies that are making these tools, or just states. It's large purchasers. So GE has a price cost estimator tool for patients. Most of the big health plans have some version of this. And really what they're trying to do is route patients to a low-cost provider versus a high-cost provider. They don't really do much once you're already in the door. So I told you about this essay contest thing that we did. We converted that over recently. We're still doing it as an essay contest, but we've now started to embed this within the profession. That's been like a major mission of our work, and we have a series now in one of our major health journals where we invite people to write these short vignettes and connect them with evidence, where there are examples of harm from too much medicine, based largely on the fact that we know that harms from too much medicine are equally common as harms from too little medicine, and yet it's really the latter that most of us are trained or learn about during the course of our training. So about 4 or 5 years ago, I think one of the first folks to kind of pick up on this trend towards trying to bring cost information within the doctor-patient relationship was the management consulting company Bain. It wasn't my profession. Very little gets by Bain. But they put out a white paper called The New Cost-Conscious Doctor. And this was actually pretty paradigm shifting. Because they asked a couple of questions. One is, doctors, do you think that costs are part of your responsibility? 80% said yes. And since there's been a big paper in JAMA that surveyed 3,000 doctors, found pretty much the same. Actually, it was more like 96% felt like it had some responsibility for healthcare costs. Quick to blame medical malpractice and insurance companies and other people for it, but 96% owned some of it. The interesting people were the 20% who said that they had nothing to do with it. So they asked them, okay, you don't think healthcare costs are part of your responsibility. Do you think that they're influencing your decisions anyway? Compared to 5 years ago, do you think healthcare costs are increasingly influencing your decisions? Most said yes. And then when they were asked to project into the future, which is basically today, more than 2/3 of doctors felt like, yeah, of course, healthcare costs are increasingly going to explicitly enter into the decisions I make. And so this is sort of like the reality that we're living in right now, where patients come to me. And I should mention too, as a resident, your job isn't to take care of the people with a lot of cash to spare. You take care of the down and out. Those are the people that come to residence, the most price sensitive patients out there. So I noticed a palpable difference between when I started my training and today in my clinic, in the number of patients that come to me and have questions about the value of what I'm recommending. For most doctors, you may as well blindfold them, spin them around, and ask them to pin the talent donkey when you ask. So there's been a bunch of studies now that have shown how little we know. And one of my favorites, it's really actually deeply troubling, but it was in the Journal of Hospital Medicine, where they asked hospitalists who spend all their time in hospitals to estimate the cost of commonly ordered tests within a hospital. And they had to graph their guesses on a log scale, because they vary by orders of magnitude. The people that know what a log scale is, all the nerds in the room, their mouths open. So how do you bring clinicians on board? I think one of the first things that we have to do is figure out, most physicians in particular see themselves as victims of the healthcare system, just as much as anybody else. This is like the fourth stool in the triple A. And the question is, how do you empower them? you have to be able to forgive them for the things that aren't their fault, and be able to focus in on the margin of healthcare spending that are really directly within their control. So IOM and Congressional Budget Office and other people in the know say that every year we spend about $800 billion on tests and treatments that don't make patients better. So just to kind of provide a frame of reference, our total direct spending on the Iraq War from 2001 to 2009 was about $800 billion. So apparently we spend every year on tests and treatments that don't make people better, measurably. The trouble is, and of course, it's people like me that order those tests. Well, part of the issue is that, ex ante beforehand, it's hard to know what's going to measurably improve a health outcome. So you have to give a little bit of leeway for that. We talked about this morning about how the majority of healthcare costs are fixed. And so, we were saying maybe like 70, 80%. So, if I work at the Brigham, it costs a lot of money just to turn on the lights. There's a helipad on the roof, there's a big blood bank to maintain, there's like 52 operating rooms. So an echocardiogram at my hospital costs more than an echocardiogram across the street. And I'm not sure it's necessarily my fault as a forward deployed clinician. So you forgive that. At least it's a non-starter. And then, a lot of healthcare spending is genuinely like patient demanding. It is. I think as part of this, we can include end-of-life care, in the ICU, maybe. And things that are at least, they're things that we need to talk about, but certainly not low-hanging fruit. And you forgive that too. And you're still left with about $100 billion that clinicians can directly return to the wallets of the American people just by making different decisions at the point of care. It's a pretty big value proposition. So when I started this work, because I was a trainee myself, the lens that I was looking at everything through was education. It was like, it's totally a pipeline issue. And part of it too is that, most of the people that wrote to me when our website was getting all those Google hits were young clinicians who saw the writing on the wall, just like me, and saw the rest of their careers ahead of them and wanted to think through what we could be doing differently. So one of the first things we did is think about what is it that physicians need to know in order to make these decisions. Do we give everybody a course in health policy? Do we bring them up to speed with what all of you guys know? One of the challenges that we had to grapple with right away is that doctors are trained to take care of the patient directly in front of them, not to assume responsibility for populations, which is ironic because most ACOs have some kind of department of population management, and it feels incredibly abstract. Like, we know that healthcare costs are 18% of GDP, and we're wasting $100 billion, and we're smart, and we know that's bad, but that doesn't inform how you take care of patients differently. And so what you have to be able to do is reframe cost conversations within the doctor-patient relationship. And honestly, it's becoming easier to do because it's becoming an affordability issue. Patients have $5,000 deductibles. Part of the reason why I know that teaching everybody health economics or health policy isn't the solution is because I have access to a unique population of students where, at Harvard, all of them take this intro to health policy course. That's like ridiculous. They're so spoiled. It's, Don Berwick and Atul Gawande and all these people. They're pretty informed. And then, because they're all overachievers, a lot of them get MBAs and MPHs. Some of them even have PhDs in economics. And so I asked them, do you feel prepared to integrate costs into your clinical decision making? And the overwhelming majority feel utterly unprepared despite all that training. And the most interesting thing is that the more training they had, the further along they were in medical school, or if they had a joint degree like a PhD in economics, they felt even less confident than the first year medical students. It's more like the more you know what you don't know. So it's got to be something else. And then okay, well maybe we can teach them cost accounting, but I think, well, there's that, but then as you all know, every stakeholder in healthcare values care differently. And particularly at the point of care, there are these massive information asymmetries. So part of what we need to do is take our clinical knowledge, where we're on one side of this major information asymmetry. We actually know something about the test we want to order and how it could help the patient in front of us. And somehow leverage that to drive better decisions. The other issue, I usually, this is a generic medical bill. What's on it doesn't matter too much. But I put this up when I talk to physicians, and the first problem is that the 30 seconds that it's up is the longest they've ever looked at a medical bill. That's problem number one. Problem number two is that most of the prices on here are arbitrarily determined and inflated. But as we said, clinicians don't decide prices at the point of care. They don't. Some clinicians have some price setting ability, but it doesn't happen at the point of clinical decision making, so that's not really your lever. The lever is the third thing, and that came up today also in our discussion, which was that a third of the line items on this bill don't need to be there. They could be completely struck away, or they could be replaced by things that cost less money that would get the patient to the same place. And that's the part that's right in our wheelhouse. That's the part where, in theory, that's what we know about. And it's the thing that we directly determine. So part of our thinking, too, was kind of starting with this thing that became a buzzword when I was in medical school called evidence-based medicine. And even then, I wondered if we weren't doing evidence-based medicine until now, what was it? But one of the things that's come along in the last few years that's made a lot of this work possible is the Choosing Wisely campaign. And I think Maine actually has been a grantee of Choosing Wisely campaign. But basically, what they did is they got most of the professional, societies together in medicine, not just physicians. And not just primary, there's primary care, cardiology, nuclear imaging, nurses. The nurses are going to come out with their list, I think, in the next couple of weeks. Dentists, physical therapists, patient partners, consumer reports, AARP. They came up with these lists of 5 tests that clinicians and patients should question based on the evidence. What was brilliant about it is that they took the existing evidence and they reframed it. So instead of being evidence for the things that we should do, this is meant to be evidence of the things that we perhaps shouldn't do. But there are 2 limitations to evidence. One is that almost every study that we do in healthcare is based on epidemiology. And the way epidemiology works is that you focus in on population averages. No patient in front of you thinks that they're the average patient. And they're right. There's a lot of variation around the mean. And so there are a lot of things, between every single guideline, there will always be a lot of wiggle room and room for discretion. As an obstetrician, I'm responsible for most of it. One of the services that varies the most in this country are C-section rates by hospital, which vary between 7 and 70%. None of that is explained by patient characteristics, literally 0. A lot of room for discretion. So what do you do about that? And just by way of example, I have 4 ways of taking out a uterus. I can use steel instruments. I can do a traditional laparoscopy. We'll condense it into 3. Or I can use a $2 million robot. And it's really hard to make a guideline about which patient is appropriate for the robot. Or the other thing is I do a lot of ultrasounds. Apparently when I was born, ultrasounds were just becoming a thing. And now it's pretty routine that I do 4, 5, and for some patients, 5 is valuable. For other patients, the 5th one is considerably less valuable than the 4th. And payers are starting to push back on both of these things. The big limitation of evidence, though, is that, we've known we're supposed to wash our hands for 150 years. And we're still working on that. The inflection point, where we start to get better at hand washing, we're still not perfect, was when I was a trainee, and we didn't get better by showing people the 150 years worth of evidence. We started to think about what the barriers to hand washing were, and started systematically solving for them. So, I remember one day, literally overnight, hand sanitizer becomes a thing. And they're not randomly located, they're strategically located throughout the hospital. We take hand washing from a 5-minute operation to a 30-second operation. We create these 360-degree feedback systems. So in my hospital, if I don't use the Purell before I walk into the patient room, if the nurse doesn't call me out on it, the patient will. And probably most importantly, we started connecting actions with consequences. So, if you're the one, we started flagging hospital-acquired infections. So if you're the one spreading MRSA around the hospital, it gets super awkward for you very quickly. And you can't watch it out better. And so there's a similar opportunity here. I think, in the interest of time, let me try to give you a couple of take-homes about how to think about this. I lost my animations in the process. They were of converting this over, I think, which is a little bit unfortunate because you've got all the answers in front of you. But one of the opportunities right away is to start with this discomfort that clinicians have about thinking about costs. And most of the discomfort comes from the fact that we care about the patient in front of us, and we care much less about the societal resource stewardship piece. We care about that, but it's abstract. So, this is just stupid. We made a stupid 2x2 box, but you have to separate them. And there are some things that we do that are good from a cost perspective for the patient directly in front of you, and good for society. It's like an all-around win. There are other things that are bad for the patient in front of you and bad for society. And there are other areas where these things are in tension. But until you sort this out, you can't even start to work through how to address them. So things that are good for the patient and good for society. Can you guys think of any?
Immunization.
Yeah, vaccines are a great example. Generic drugs, great. Everybody wins. We don't do those things well. Things that are bad for everybody. Proton beam therapy is my favorite thing to pick on.
Overexposure to radiation testing.
Oh, sure, yeah, absolutely. But with the proton beam thing in particular is killing me, because it's the number of proton beam therapy centers in the country in the last 5 years has doubled. Meanwhile, there's no evidence. Everybody is saying there's no evidence whatsoever that it improves care, and it's 6 times more expensive per treatment than the alternate form of treatment. And it costs $150 million to build a facility. So once you build it, you've got every incentive in the world to crank people through it as quickly as possible. For these issues in between, I think in the issue of time, I'll skip it, but at least by coming up with use cases that fit into each box, you can have something concrete in front of you to sort of think through how to address it. The other piece is that, just like with hand washing, you have to understand why clinicians are knowingly over-ordering tests. And the whole public discourse about this is about 2 things. It's about fee-for-service medicine and ordering tests because they're trying to make more money, or medical malpractice, doing things defensively. And the insight that we had on this was that some of the most expensive places to get healthcare in the United States are academic medical centers. In those centers, residents pull all of the levers. They do all of the ordering. And yet, interestingly, number 1, they're indentured servants. They don't make more money for doing more things. And number 2, they're they could get sued in theory, but they're very protected when it comes to medical malpractice. And yet, they're still rampantly over-ordering tests. So we asked them why. And we came up with a list of 20 other things that nobody was talking about. Well, people were talking about, but they weren't framing this way. And then we bundled them into a top 10 list. So just to give you flavor of this, if you're in the emergency room and you're being totally hammered, you've got 1 million patients to see, your number 1 incentive in life is to unoccupy the structure in front of you. And so you have a choice between ordering 5 tests at once and not thinking about it again, or ordering 1 test, waiting for the result, and then thoughtfully ordering the second. And that suggests a different solution from a systems perspective to the problem. There's this thing where doing more is equated with being thorough in medicine, and that's a cultural thing, but the way that gets operationalized is really interesting. So I'm an OBGYN, which means that I'm only really aware of about 3 antibiotics. And but by contrast, I've got colleagues that have a much more sophisticated understanding. So I admit a patient who I operated on who has an infection. I give them the 3 antibiotics I'm aware of, and it's not working. So I get a consultation from the infectious diseases folks, who right now are very tied up. The way they roll, this is true almost any medical center you go to in the country. They'll literally sit down and write everything that it could be and all the ways that I could test for it. That's how we're trained. And then because I'm not the expert, I defer to them and I order all of those things. That happens every day, all the time.
Yeah.
And then, of course, there's the piece that, we were talking about a lot today. It's understanding how much setting affects costs, but also understanding how much clinicians can affect the setting in which people get care. So the same echo or CT scan in my facility is twice the cost as getting it elsewhere. And how do you think through that? These things are so common that we were able to take all 10 high-yield reasons that aren't medical malpractice or fee-for-service and bundle them into a 2-minute video that we thought was completely plausible. I can't show this, but it's online. And basically, it's a team, an inpatient medicine team, who admit a young woman with a kidney infection. And in 2 minutes, they have a conversation that brings out all 10 reasons. And we made this into a module where you get primed to the 10 reasons ahead of time. You watch a 2-minute video. Then you have to find them like a Where's Waldo. So there's a validated instrument on the back end that proves you've learned something. And in 10 minutes, you can move somebody through, prove they've learned something, and prime them to the things that they're doing every day that might be at least lower hanging fruit than reforming medical malpractice. We then sort of moved on to, incentives are still a little bit high level. So we tried to get even more concrete and give people tools for something that all of us do very commonly, which is prescribing medications. Turns out there are many published evidence-based strategies for helping patients better afford medicine that goes well beyond generics. So trying to bundle them and give them out. And then at the end of the day, even if you build the will for change and you've got engaged clinicians and you've taught them what to do, you can't put them back into systems that set them up for failure. So how do you help support them? And there are many ways that you can do this. One way is that in the modern era, at least the residents look something like this. They've got a computer, they've got their smartphone. And in the last 20 years, we've actually made patients much, much safer by using our computer systems to help support better decisions. So, it's early fall, it's a time in academic medical centers where there are a lot of new doctors around. You can always, usually if you got a trained eye, you can spot them. They're a little nervous. It's really hard for them to hurt patients. Because if they try to order a medication that the patient's allergic to or that will interact with something else they're on, the computer will yell at them. There's a huge similar opportunity to not just think about safety, but value as part of the same equation. You guys know Abraham Verghese, who wrote Cutting for Stone?
Yes.
So he has this quote that I really love about this, where he says, if you're ordering off a menu that doesn't have any prices on it, it's really easy to get the filet mignon every time. And so, one big opportunity is just to put prices back on the menu. So right now, the way I order an MRI is by sitting down and just clicking with my mouse, and it's ordered, and that's it. In fact, as an intern, I moved hundreds of thousands of dollars around without ever knowing it, and without any oversight. And real-time price adjudication in healthcare is nearly impossible, but it also turns out that it got figured out decades ago that you don't need dollars and cents to drive good decisions. You can just do order of magnitude, like $4 signs or $2 signs. And there's so many decisions that we make every day that are literally like 2 orders of magnitude apart. And if we stopped and thought about it, it wouldn't make a difference. The other opportunity is to just use behavioral economics. So, school cafeterias now are putting high-calorie soda in the back. Same thing. When you admit a patient, there's a menu of choices, and you can put the high-yield stuff up front and make it 2 clicks to get to the low-value test. You can create what are called forcing functions. So if you're trying to get a really expensive test, you can just saying are you sure? Yes, click. It's been shown makes a big difference. So there are big opportunities here. We're sort of at the beginning of this. I mentioned the C-section thing. I'll say really briefly, this is the one that gets me, I spend a lot of my time thinking about right now because there's just so much variation. It's how we're born, so it matters to all of us. And here, I think this was a really interesting frame to think about discretionary decision making because you're choosing as the clinician between, how many people have kids here? So a C-section, I put 2 hours to be generous, but a primary C-section takes me less than 30 minutes. Everybody here who has a child that was born the natural way knows that it doesn't take 30 minutes. And so,
Particularly the mother.
well, that's the thing.
Zero on that.
But for the clinician, it's a choice between like 20 hours of clinical attention or 2. And so there's this implicit baked-in incentive to expedite childbirth and offset your workload at all times. And it turns out that, first of all, if patients don't explain the 7 to 70% spread, it's got to be something about the institution. It has to be. In fact, the #1 predictor if you're going to get a C-section in the United States is which hospital you walk into. These are like all true facts. And so, we're starting to think through like what that is and why it's so different in different places. And it turns out like operational management impacts performance on the Toyota assembly line and in our hospitals. And so we're starting to think through how that works. I think, the conversation this morning started talking about the aspirational goals of the coalition and, whether or not they're aspirational enough or even realistic. When I started this work, I had the same question myself. Part of what I think has really helped, though, is to know that we've done similar things before. There's obvious parallels between environmental movement, what we're doing in healthcare right now, it's stewardship. But it was basically students and their professors on college campuses that made it awkward for me to litter. In fact, Judy had to talk me through like the dump recycle thing with my coffee cup. I mean, like, there's like peer pressure. If I go back to my hospital, which I'm going to today, and ordered an MRI for a patient that didn't need it, which I won't do, I'm not sure who would even bat an eye. But that's where we need to go, and I think that we can do it. So I'll leave it at that. I think pretty much at the end of time, but I'm happy to answer any questions or. So I didn't mean to talk at you the whole time. I apologize.
Go ahead.
So how open are your colleagues, the young doctors, the middle-aged doctors, the retiring doctors, to having a conversation about what not to do? Are you unique? What's happening?
I'm less unique. Like, this didn't get me a lot of friends at the beginning, particularly as a young physician. Like, it's easy to get perceived as a whippersnapper. And, for a lot of reasons, it started to change. But I think part of the trick is to pick the right use cases, because this is aspirational thinking in a lot of areas of healthcare, but not in all. There are a lot of services that are like high volume and low margin, like labor and delivery, like everything that happens in the emergency room, where you could think about how clinicians can do things differently in ways where everybody wins, the patient in front of them and the institution. You wouldn't start in a boutique dermatology clinic, probably. But that's part of it, is sort of thinking about how you thread the needle so that there are multiple wins, realizing that for the physician, for the nurse, it's really the patient in front of them that they care about most. And I think actually, when you make it a professionalism issue, most people come on board pretty quickly. That was the brilliance of the Choosing Wisely campaign. Like, they did something that nobody would want to touch with a 10-foot pole after 1994. And the reason they did it is because they made it about professionalism. And to this day, I've actually never heard a doctor get called unethical or unprofessional to their face for ordering a test that a patient didn't need, to this day. But that's really what the Choosing Wisely campaign was trying to do, and that's the world that we're entering into. There's like there's nothing worse you can say to a doctor than to call them unprofessional, and that's sort of where this is headed.
I have a question. You used the phrase like tests that don't make people better or low value tests. So how effective does a test have to be for you to consider it a high value test? Is it like 50%, 70%? The severity of the illness, if they do have it, like what makes a test to you high value?
Well, what makes a test high value to health economists in the United States is that it costs less than somewhere between $50,000 and $100,000 per quality adjusted life year. kind of a weird thought. And like the way that you get there is by, I mean, there's a few ways. One is originally it was based on how much it costs Medicare to take care of a dialysis patient for 1 year. Then economists came up with clever ways of looking at revealed preferences, decisions that we make where we put our lives at risk every day, how much you're willing to pay for a smoke detector versus the risk of a fire, how much you have to compensate a construction worker for being on a high-rise building. And what's interesting is, like, no matter how you look at it, pretty consistently, it's a year of life apparently in American society is worth $100,000. Now, like, that's not super helpful for the people that are on the ground. And part of the reason is that those are, again, based on averages. And we don't deal with averages when we're caring for patients. In fact, the whole reason that you need a doctor and not a robot in 2014 is that physicians and nurses are able to account for some of the variation around the mean. And so what you have to be able to do to figure out if it's truly worth it or high value or low value is think through it, with the patient in the loop. Like as I said, I've got plenty of patients for whom, like, you need at least 5 ultrasounds, maybe more. Most of my patients don't need that though. And it's really hard to create a guideline because of this issue of averages versus, what's happening at the margin.